healthcare systems and real solutions to these healthcare systems. So moving on, I would love to specially, first of all, I want to apologize to our speakers before introducing them. We are sorry for keeping you waiting. I hope our
Sorry,
apologies are
dirty.
accepted.
Instagram was just doing us dirty. Oh my goodness. Instagram. Oh my god.
Okay, so we have wonderful, really, really wonderful women joining us today as speakers and
Sorry,
our lovely host.
sorry.
I
Please
read,
permit.
I read.
Sorry, before you go, I permit me to. Would I say mute my
We
mic?
can't hear
Right?
you.
Can you hear me now? Okay, I said permit me to mute my mic and my video. Share the link with our community manager so that she can apply it
Okay,
so that we are on. Yes, but
all
please.
right, that's fine. All right, ma. Okay, so I'll be introducing our speakers now. We have an incredible lineup today. I'm not even going to lie. Trust me, today's session, if you're not here, if you know anybody that needs to be in this session, just forward it to them because I believe and I know from the bio, the research I did regarding our speakers, I can tell you for sure that you must live with something. You must learn something new. You must be educated. You must be empowered. You must be encouraged to stand up for women's health as well. So they have different, I really love how they have different perspective in attending to health issues in their various countries. So we have the first speaker. I will starting first with Mrs. Sarah. I don't know if it's Mrs. I don't know. Miss.
Yes, it's Miss.
All right, sorry. Miss Sarah Nkasa Boateng. Did I get that right? She's also known as the global nurse, the
No,
global
I'm a
midwife.
midwife.
Yeah, she's known as the global midwife. She's an award-winning midwife and maternal health system innovator and the founder of TTYM Global, which is Talk to Your Midwife, which is a marketplace. What's the word? She goes to the marketplaces to do marketplaces in antenatal. And I think that for people that are really struggling in Africa, as women that are really struggling, most of them, their excuse is, oh, I'm going to work. I don't have time to come to the hospital for antenatal. And I really think that that is a very good initiative. Welcome, Ma. We really love having you here. We really love to learn a lot from you today and know your perspective on different things as we go on. She has a long list of achievements. She has a long list of achievements. She helps underserved communities. She serves as a United Nations volunteer and a UNFPA Youth Leader Fellow, championing youth leadership and maternal and reproductive health equity. She integrates clinical expertise, youth leadership, and systems thinking to influence maternal health policy and expand access to quality care. Because, I mean, do you know how many women are in the market? Imagine going to the market every week. That is a lot. You've spoken to over almost, let me say, millions of women. Yeah. So it's a really great thing to have you in our midst, Ma. She's also recognized as the Eastern Regional Best Midwife 2025 and one of Ghana's 100 most impactful young change makers. Can you see that she's not a small person. She's a very, we are welcome, Ma. You are welcome, Ma. It's a pleasure to really have you in our midst. It's a pleasure to really have you in our midst.
It's a pleasure to also be here to share my knowledge with you all.
Thank you, Ma.
Can I
So
be
we'll be
heard?
moving on to our next speaker. Hello, Ma. Anita.
Hello, Vivian.
Good afternoon, Ma. Yes, we want to
Good
see your face. We want to see your face. Welcome to
Yeah.
this session, ma. We really appreciate your effort and taking out the time to be here. So, Madam Anita Francis Nganga, did I get that right?
Yeah.
She's an award-winning midwife as well from Tanzania. I think if not that, I don't know if our emojis are working. We should be clapping in the comment section or chat session because the people here, like they didn't come to play. I'm very sure you people are with your jotters and biros and everything because the people we have here today, you must learn something. She has over 10 years of experience in maternal and newborn health. She's a final year BSc midwifery student at Aga Khan University and founder of Midwife Anita's Breast Nest. She's a maternal health initiative, which Breast Nest is a maternal health initiative focused on breastfeeding education and postpartum support, which is one of the most important aspects of maternal and child health because exclusive breastfeeding, we know the importance of exclusive breastfeeding. And the ability to have postpartum support in this area of the world, it's very important because with the increasing rate of postpartum depression, having postpartum support is something that helps mothers, new mothers, to survive that phase. Yeah, if I can say that. She has supported more than 8,600 mothers and users using, and she used digital platforms to educate and empower thousands of women across Tanzania and beyond. It is with great pleasure, ma, that we honor you today. We really appreciate you taking out your time to be with us today on this session. While our host is doing some household jobs, we would like to introduce her as well. She's the founder of Natal Care, my oga, my boss, my mentor. She's no other person than Mrs. Kauta Opeyemi Lawal. She's a public health advocate. She's a midwife nurse and visionary in the maternal health space. She's a certified public speaker at the intersection of advocacy and inequality. Madam Kauta has dedicated her career to advocating, educating, and empowering women with adequate knowledge to combat maternal mortality. This is inspired by nearly losing a dear friend to postpartum hemorrhage. She has contributed to several advocacy efforts, including the stigma film on sexual violence, the Lagos State Stop Policy, which is safe termination of pregnancy, and the family planning campaigns. And from where I even knew her from, she hosted a webinar last year's International Women's Day. She hosted a webinar on beyond the symptom, PCOS symptoms. So really want to give it up for her. If you're in the house, please drop your emojis in the comment box, in the chat box. We want to see the fire. We want to see that we are together. So let's appreciate our speakers once again before we go into the panel proper. So please let's drop our comments in the comment section. Let's drop our comments in the comment section. Thank you so much to our host for making this possible, for bringing us together, and to our speaker once again. We thank you so much for coming, taking time out of your busy schedule to grace us with your presence. So moving on, we'll be moving to the panel, the discussion immediately. We've wasted a bit of time. So Miss Sarah, I would like to ask you, what do you think are the key barriers to equitable access to maternal and reproductive health services in African countries? Miss Sarah, are you with me?
Yes, yes, I'm here. Sorry.
All right.
Yeah. Can I be heard?
Yes, we can hear you loud and clear.
Okay. Thank you very much, Vivian, for your kind introduction. And I want to use this opportunity to also thank Kauta for this great opportunity to add my voice to this very important conversation. And it's a pleasure to meet you, Anita. It's a pleasure to meet you, and I can't wait to also learn from you as
Thank you.
well. Yes, so the issue of maternal health equity, I would say that it's something that when you enter into policy boardrooms, it's being said, they say it, that's the vision that they want maternal health equity. But sometimes we equate equity to access, that the fact that there's availability of the hospitals or the availability of the facilities, we equate that to access, which is not so. But I would say that equity is giving everyone the opportunity or access to the same level of care, regardless of where the person stays, the person lives, what the person does, or sorry, where the person lives or the person does. I'm sorry, I was a bit distracted. Okay. Yeah, sorry. So I was saying
Sorry.
that for me, yeah, I was a bit distracted. I'm home, so a bit distracted. Yes. So I was saying that equity is giving everyone the access to the same level of care, regardless of where the person lives, who the person is, what the person does, or that. But sometimes, as I said, we equate the availability of these facilities to mean that the people have access to it. When we talk about equity, we can talk about four main things. That is availability of the hospitals, accessibility. So the hospitals are available or the clinics are available, but are they accessible? Are they affordable? Can the people that you have created these facilities for, can they afford the services? And also, is it acceptable? Is it culturally sensitive? Are the care that being provided in the clinic, the various clinics, are are they are they culturally sensitive? When we take affordability, for instance, for Ghana in context, we have the National Health Insurance, and the National Health Insurance is a scheme where every pregnant woman, if you have your National Health Insurance, you access free health care wherever you go to. But sometimes this policy falls flat because there's out of pocket expenses. These women go to the hospital knowing that, oh, I have a national health insurance, and that um I would have free access, or I'll have a free service, but then they end up paying for things like laboratory investigation and all. And sometimes it is not the fault of the hospital, because some of the insurances, it has to be reimbursed by the state, and sometimes it doesn't come in on time. So the hospitals would have to find ways and means to also sustain the work that they are doing. So I'd say affordability is one of the problem that the barriers to maternal health equity, and accessibility. So just like the work that I do in the marketplace, so it started when I was working in the hospital. I realized that we have the hospital. My hospital is like 10 minutes walk from the market, but still the women were not coming. And when I had a conversation with them, they highlighted that they don't have time to come. Right. For them, when they leave their work, it means they're going to lose vital income, and they need this money for to come to the hospital and pay for whatever they have to pay for. So they will rather stay and be responsive. That is, they'll only come when they have a problem. So they are not practicing preventive health care. That is, they coming
Yeah.
for routine checkup, but they will come when they have a problem. So once they don't have a problem, they are there. And for me, it was alarming because no one knows what will happen. Pregnancy is unpredictable. And so routine healthcare checkup is very important. So that's led me to my market antenatal. So it is not just an outreach I do in the market, but we have a structure in the marketplace where we provide consistent
Oh.
antenatal care for the market women. They're trying to bridge the gap of accessibility when it comes to maternal health equity. Yeah, so I and the quality gap, there's a quality gap when you compare the urban areas to the rural areas, you realize that there's a huge gap when it comes to logistics, supply chain. You realize that there's a huge gap in the rural setting. Some of them do not even have the requisite things to help them practice. They are always improvising compared to the urban spaces. So I think the barriers to maternal health equity, we can talk about accessibility. That's the geographic gap, poor road network and all that, accessibility, how the people are even treated, how the people are treated when they go to the hospital. You know, Africa is more cultural, and we are family people. We want to feel belonged and loved. So when I come to the hospital and everything is being rushed, I'm not sure I would want to go there again because I'll feel like I wasn't accepted, you know. And it's sometimes it's not the fault of the midwife. The ratio of midwife to clients is is wide. You would see
Yeah.
one midwife taking care of about 10 pregnant women. There's burnout. So sometimes I'm not trying to justify the sometimes the
Yeah.
behaviors of the midwife, because sometimes it's understandable. And so these women will not come for healthcare, right? And when it comes to also access to family planning, especially the young people, they feel stigmatized. They feel stigmatized. And also the fact that in Ghana, your husband has the upper hand or has
Yeah.
the decision rights over your body as a woman. Sometimes when you think about it, it's crazy. Some women would literally sit at home because their husband says so. Do you get it? Some will not come in for contraceptives because their husband says so. So some of these things also, it hinders the maternal health equity. Yeah.
All right. Thank you so much, Miss Sarah. But regarding these women not coming because their husband says so, I thought the WHO gave a um bill, I think in 2022 or 2023, that every woman is entitled to make those choices for herself.
Yes. So you see, when it comes to policy and its implementation, sometimes um when it comes to implementation, there's what's the word? There's a gap. When we are designing policy, sometimes it is not co-created with the people. So as I said, Africa is more cultural. This is what
Yeah.
we grew up to know. The men are the head of the family. The men decide in the family. So when you go to a typical community in an African setting, the person waits for the husband. Sometimes they come after birth and they don't even have money to pay, and they'll tell you, my husband will come and
Husband
pay
is
for.
coming.
And sometimes CS, in dying moments that we need to make a decision, she'll tell you, I have to call my husband before I do it. So in as much as there are policies that are guiding all these things, there's even male involvement where we encourage male involvement in Ghana.
Yeah.
When you come with your partner, we serve you first, we give you priority, and we serve you first as a means of encouraging the women to come with their husbands, for them to also come and listen to the education that we give to the women. But they
Yeah.
still don't do it. They still don't do it because they're not seeing the relevance, if I should put it in that way. They're not seeing the importance of leaving whatever they are doing to come with their wives. They feel when the wife is pregnant, it's just her cup of tea to figure things out. So true, there are policies, but policy designing and implementation, there's a gap in between that needs to be fixed. Yeah.
All right. Thank you so much for that answer. So this will move us to the next question, which I'll be asking Madam Anita. Madam Anita, are you with us?
Yes, I'm here.
Okay. So the next question, I would like you to answer that for us because I think it's leaning more into your perspective of maternal reproductive health. So the question is, from your work, where do you see the biggest disconnect between how maternal health care is designed and how women actually experience it. And how do social determinants like poverty, education, and culture impact maternal health outcomes in your experience? Did you get that?
Pardon, please, can you repeat? Sorry.
Okay. I said, from your work, where do you see the biggest disconnect between how maternal health care is designed and how women actually experience it? And how do social determinants like poverty, education, and culture impact maternal health outcomes in your experience?
Okay, thank you so much. If we look at maternal and reproductive health across many African countries, we can see the key barriers is to equitable access remaining quite consistent in many communities. But we are dealing with a combination, most of the time, of combination of limited physical access to services, financial barriers, shortage of skilled health providers. In some hospital, especially dispensary, there is a medical attendant who provide care other than nurses who have license or a midwife. But also, critically, there is a gap in quality of care being delivered. But beyond this structure issue, social determinants, I see social determinants play a significant role, such as poverty, low level of education, cultural dynamics. Often they make women to delay seeking care behavior and limited women's decision-making power regarding their own health. As Sarah said, most of the African regions, uh, their husband have a power, they have the last say in the family. So the women cannot make decision on her own, regardless of maternal issues. And from my experience, one of the biggest disconnection in the maternal health is that maternal health care system are often designed around service provision, while these women are experience this care as a journal. This journal that's frequent, fragmented, delayed. Sometimes they face lack of dignity. But our service, our provision of care is remaining to provide service only in the healthcare facility rather than dealing directly with women issues that we face in this journal. And beyond these statistics, the lived realities of women, including some women, they live far away from health facilities. Uh, you can see a woman live 10 kilometers from dispensaries. There is consistent care at home, lack of postpartum support, caregivers. There's no one who can take care effective of these women. And in some cases, there is respectful treatment within the facilities. As a result, certain groups remain consistent and underserved, but also particularly women and the adolescent group and those low income communities. And all this ultimately affect trust. And as we know, trust is a critical because when women lose confidence in the system, the delay of getting service or completely to avoid seeking care is occurred to women health. Thank you.
Thank you so much, Madam Anita. Thank you so much. So, still on, what are the lived realities of women that current maternal health system are still failing to capture? I would like to ask Mrs. Kauta, because that links towards her field, policy, and that perspective. So I would like to hear from you about the lived realities of women that current maternal health systems are still failing to capture.
My goodness, that's the reason why I like to confirm if anybody can hear me. Thank you so much, Vivian. Can anybody hear me?
Yes, we
Confirm it.
can now.
So
Yes, I
thank
can hear.
right, yeah. Thank you, Anita. Thank you, Sarah. Before I go to the lived realities of women, I would like to say something because while I was doing the stuff of sharing and everything, I was listening to Sarah while she was talking, and she mentioned two things that was really stuck with me. And she mentioned the issue of policy. Policy is one, practice is one. See, the people that are making policies, I have a problem with when people are making policies. That is why I am interested in policies, right? Because as midwives, we need to be in a position, we need to be in that corner where they are making the policies because we know the issues, we know the difficulties, we know the problems these women are facing. We can best tell them these policies are not favorable. If you want these things to be done, then you have to do it in another way. Yes, what else organization or whatever it is, they make a policy that a particular woman has a right to make her own decision, sign her own papers. She has an individualized right, but do they really go into the communities? Do they know what is happening? They do not know what is happening. 70% of women that are coming to, let's say, hospital, or that are not even going to the hospital, that we attend to in the community level. Trust me, just like Sarah said, 70% of these women, they'll see cultural barrier. A lot of times is their partner that is making decisions for them. A lot of time they can't make decisions on their own. A lot of time they can't even do certain things on their own. So when they are making those policies, when not involving us, why we are telling them that, okay, this policy cannot fly if really we want to make maternal health equitable and accessible for all. This policy cannot fly. However, why not we do this? Why not we include the men? Why not we capture them in the conversation? Why not we have them with us rather than saying a woman has so right to do so many things by herself? Yes, we know that on reproductive health or maternal health, a woman can make choices, right? It's a fundamental human right. But are we thinking of the culture? Are we thinking of the barriers? Are we thinking of the funding? Are we thinking of so many things women are going through before we make those policies? Unfortunately, they are not thinking of those things. They just make these policies. These policies are not favorable, and you see that you're not getting results. The reason why they're not getting results is because they haven't talked about the real issues. They haven't tackled the real problem. So thank you, Sarah, for saying that. Policy is one thing. The realities of women is another thing. And it's those realities that we face every day. So that is why I'm so much particular. Anytime they're having briefing, anytime they're having government sitting, anytime they're having, I want to always involve in a conversation because these people do not see what we see outside. These people do not see what we face outside. They're just, oh, maternal mortality is high. Why do we keep going in cycles? Why are we this? Why are we that? Why are we not in the next phase? You can't be in the next phase if you're not doing the right thing and you are not reaching the right people you're supposed to reach, rather than just saying, oh, we are making the policy. As far as the policy is there, the policy should serve the people. It can't serve the people because you didn't make it right for the right people, right? So thank you, Sarah, for saying that. I just wanted to say that quickly. Then I wanted to say one thing again about what she said, or maybe I'm going to talk about it after our, or as we go on with our discussion. So for the question you gave to me, you said, what are the lived realities? Can you come again with the question so that I could answer the question?
Okay, can you hear me, ma?
Yes, I can hear you.
Okay, so the question is, if we look beyond statistics, what are the lived realities of women that current maternal health systems are still failing to capture?
Okay, so when we look beyond statistics, right? Yes, everybody is talking about the numbers, the numbers, the numbers. Yes, the numbers is there, but there are so many lived realities that a lot of people are not still talking about. Now, these lived realities are still linking to the numbers. Before the numbers are there are a lot of issues that are underneath. As a matter of fact, these issues I'm going to talk about, or I'm going to mention, they are the one leading to the high maternal mortality. Number one, let's talk about access. how many for the communities we penetrate? I like the when Sarah was saying something about the marketplace, going into the marketplace because she saw a problem, because she saw that a lot of women could not come to the health facility, no matter how closer is it to them, or no matter how far it is to them, they cannot come to the health facility and access midwifery care and the rest of it. Now, access is a big challenge. When we look at the community, I'm going to use my organization for example. Anytime we go into the communities and we look at where the primary healthcare is stationed, we realize that the primary healthcare is not a central place for most people. There are some women. There was a time I attended a particular antenatal in their community, and I saw that they didn't have a lot of women. So I kept asking questions. So one of the women told me that, oh, from where they are from where she came from, and the primary health care is 500 naira. I mean, I know Sarah and Anita might not know what 500 naira. Okay, let me say 500 Ghana. At least I've spent cities before. 500 Ghana cedis is a transportation toll. Then she will take another 500 Ghana cedis back. So that's like 1,000 cedis, right? Sarah, is 1,000 cedis much for a transportation for a regular woman, or let me say a low income person?
Not at all. That's so expensive. 1,000 cedis should take care of. It should take care of you for a month.
1,000 cedis? Okay. 1,000, let me use it that way because like yeah, I used to say in Ghana and I kind of know the money. That is why I'm kind of equating it to each other,
If if
right?
if if you can give me the naira equivalent, maybe I can convert it
A
because 1,000 cedis, that's
1,000 naira,
too
a
much.
1,000 naira for transportation to and fro.
Okay.
Yeah.
Okay. So
So
that is 7 cedis.
7 cedis? Really?
Yes, that's 7 Ghana.
Okay,
Yes.
so in Ghana, what can
When we
you
come
say?
to the economy, Nigeria is on the floor. Like you guys
Yeah,
are flat.
please. We're on a national scale. Don't come and insult us on YouTube.
I'm sorry, my brothers and sisters.
You are better than myself here on YouTube. Yeah. So what I was trying to say is, okay, what can you say about us for a transition of a woman going to where she can access maternal care?
Well, that is still expensive. To and from, it's still quite expensive.
So you can
Ca-
see
Can you hear me?
yeah, I can hear you. So that's a
Okay.
lot. I don't know how it is in Tanzania. That's why I can't really tell Anita to tell. So what I'm bring out is that particular man told me that was where she was coming from. That 1,000
I
naira
think someone is giving us a feedback. Someone is giving us a feedback.
is
I don't know
Is
if it's
that you,
from Vivian or Anita.
Vivian? Is Vivian? Okay, I think
Yes.
we're getting feedback from someone. All right, so what I was trying to say is 1,000 naira can even feed a family. I mean, a family, if they're able to buy certain things, I mean, just try and buy in little quantity. 1,000 naira is not a lot of money, but it can feed a family. Now think about it. A woman who's in a community, she would rather think of using that money to feed her husband and probably her children, rather than taking that 1,000 naira to do a transportation to and fro to access maternal health services. So access is a bigger problem, and centralization of whatever it is you want them to use, the primary health care centers. Most primary health care centers are not centralized. That is the one I have seen for a fact. You can want to tell people to make use of a particular facility and you are putting it very far away from where they are. You're putting it, you can't put it in a place where they can easily, let's say, walk down, that they can, let's say, use as exercise when they walk down, or they would take probably a bike or kekeno or whatever it is, let's say 50 naira or 100 naira down to the place, something that wouldn't cost much at all. That will kind of, let me say, improve them, and that would want them to go in to take that care. So access is one of the lived realities of a lot of women. They do not have access, and like that is one of the biggest thing we are doing at Lock Natal. Okay, like we want every woman to have access. How do we ensure? I think we are all doing similar work here, and I think the reason why we're all doing similar work is because the framework kind of work. So whatever is working in one country is kind of working in the other country as well. I think I'm talking about Sarah, the work we do at Lock Natal Care, and the work you do at Talk to the Midwife here. And I think the work this lady does, this lady in Cameroon, I've forgotten her name. So we all have similar models. So that is what we are doing. Okay, if these women cannot have access to this thing, why can't we take it to them? So yes, access is number one challenge. Number two is funding. When I mean funding, low socioeconomic status, it's a big lived reality. When you go to the community, when we do our survey, when we are talking to the women, when we are getting to ask them certain questions, and we are saying, why are you not making use of this particular place for your childcare, for your pregnancy care, for your, antenatal services and the rest? What they will tell you is, I never even chop. Now that money I will can't use. I mean, so sorry to my brothers and sisters. I'm using pigeon. What I'm trying to say is I'm trying to relate in the word that they have not even eaten. Is it the little money that they have that they will use to, go for antenatal services and the rest? So I think for the people that are making our policies and the rest, they are not saying that so much. They know that there is a gap in funding, there is a gap in socioeconomic status in Nigeria. They know, but they do not know that it has eaten rotten to that extent that it's a big challenge for a lot of women to access the maternal reproductive health services. So I think those are the ones that I've seen, and yeah, that's it. All right, go
We
ahead.
can hear you, ma. We
Yes,
can
go
hear
ahead.
you.
I
All
think we
right.
have it.
So
Go ahead.
thank you so much for that answer. So still dwelling on policies, I think we should move to policies and frameworks proper now. So I'm still going to ask you, Mrs. Kauta, what are some promising policies? You've been to different conferences, you've hosted some, you've co-hosted some as well. What are promising policies and frameworks that have improved maternal reproductive health access in African countries?
Okay. So for the policies, see, um, there are kind of like a lot of policies that they have put in place, right? At least I know of a couple. I'm going to share it here. There are a couple of policies that they've put in place, but the problem is people are still not able to access this policy. Number one policy is the right to make your decision as a woman. In the past, it, in the past, it used to be a joint thing, right? If you don't have your husband with you, you can't sign certain papers. If you don't have your partner with you, you can't do certain things. If you don't have your partner with you, you can't make certain decisions. But when there was this increase in death, increase in complications, and the rest of it, the policymakers came together. They sat down and be like, bruh, we can't continue with this. Even before they made that policy, a lot of people came together, a lot of impact organization, a lot of NGOs, a lot of women in society came together and said, we can't continue like this. We can't allow a woman who got pregnant, for the fact that you carry that baby for 9 months, you should be able to have a sole right to sign your papers and say, you know what, do whatever it is to do to bring out this baby, or do whatever it is to do to bring out my baby alive and to make sure I survive as well. So one of the policy that I'm super excited that they put in was the policy of, you can do your own thing. You as a woman have a right to access. You as a woman have a right to save your life without anybody being there. Even if there is no husband, even if nobody father your child or whatever, you as a woman, as far as yes, it's funny, but there are people that get going to sperm banks and getting sperm to fertilize their eggs, and then they're fathering, they are getting their children. So in that situation, they do not need anybody. right? And the reason that made that easier was because they have made that policy, they have solidified that policy to say, you know what, as a woman, you can go ahead and do whatever it is to save your life and that of your baby. Then another policy that I know of is the VACC. Let me see. I wrote it somewhere. Please hold on. So this, I want to pronounce it. It's VACC. I want to get the full meaning. That VACC, the policy is talking about. It's a policy on sexual and reproductive health. As a woman, you have access to sexual and reproductive health. I mean, this one, I'm not talking of maternal health services, right? As a woman, you have a sole right to say, I'm going to put the full meaning of the VACC down here. But what that policy is saying, that as a woman, you have the right to, let's say, you have the right to sexual and reproductive health services and care. For example, we have, I don't know if they have this policy in Tanzania and Ghana, but we have what we call national guidelines for safe abortion. I don't know if they have it in Ghana and Tanzania, but in Nigeria, we have something that is called National Policy for Safe Abortion. Now, as a pregnant woman, you on this call would all agree with me that there are some times in the communities a lot of women do not make use of family planning, right? And because they do not make use of family planning, you see that they have like 5 children, 6 children, 7 children. One policy that I'm super excited about is they made the policy of national policy on safe abortion. Although Lagos is having that challenges, I'm among the people that is in that conversation with Lagos State, because Lagos State has banned that policy. Lagos State is saying that as far as you're in Lagos, you can't walk into an health facility to get an abortion done. Although there's a national policy that the ban is lifted, but in Lagos State, there's a ban on it. So we're kind of fighting that. Why should it be different in Lagos State? Because unsafe abortion is one of the core causes causing maternal mortality. If you look at the statistics, when you're defining maternal mortality according to World Health Organization, and you're looking at the causes, one of the core causes is unsafe abortion. Now, if women cannot get a safe abortion done, and it's directly and indirectly affecting maternal mortality, it's affecting the statistics of maternal mortality, because if a woman should die from unsafe abortion complication, they will register the statistics under maternal mortality, right? So that policy is the one that gives me joy, because for goodness sake, a woman who is pregnant, a woman who has, let's say, a lot of children, and she feels that, oh, she met with her partner and she get pregnant, she should be able to feel free, walk into the health facility and tell them, please, I want to get an abortion done. Not because I want to do it, but because I do not need this baby at this point. I already have 7 children, and maybe because they didn't use, contraceptives. But, we are not to judge, regardless of, oh, why don't you use contraceptive? Why didn't you do this? Why didn't you do that? She's already pregnant and she says she wants to get an abortion done. That policy alone, I love it so much. But if everybody can know that that policy is functioning and that policy is functioning right, trust me, a lot of people would not go to quacks. A lot of people would not get an unsafe abortion done. A lot of people would not go to someone that don't know how to do an abortion, which will in turn lead to bleeding, infection, sepsis, and even death. So that one policy itself, the national policy on safe abortion, is one I am super excited about. But just with every organization, every social impact organization coming up can let's say talk more about it, so that these people will know that you don't have a reason to go to a quack to get an abortion done. Walk into a hospital, right? Walk into a certified hospital, tell them you want to do this, and let them do it for you. Let them give you post-abortion care service. Let them cover you under antibiotics, so that you won't die, you won't have sepsis, you won't have a complication, which will lead to counting among the maternal mortality statistics. So I don't know if they have such policy in Ghana and Tanzania, but they do have it in Nigeria.
All right, thank you so much, Mrs. Kausa, for that. I didn't even know that the policy has been implemented for the safe abortion practice. I didn't know it was implemented. Thank you so much for that. So, Ms. Anita, the next question, I would love to ask you the next question. Are you with us?
Yes, I'm here.
Hello, ma'am. Can you hear us?
Yeah.
Yes, yes, Vivian, I'm here. But the environment that I'm here right now, there is a lot of
Okay,
noise.
okay, ma. So I would like to ask you this question because I want to know from that perspective. I think Tanzania is under Northeast Africa. So I think I want to get another perspective from that area, that region. So the question is, many African countries have maternal health policies in place, yet outcomes remain uneven. Where do you think is the breakdown? Is it in the design? Is it in funding or implementation?
Okay, thank you so much. We speak about the policies, of course, many African countries like Tanzania and Ghana and Kenya, we have made a strong commitment toward improving maternal health, and we have seen such promising like free maternal health services from dispensary level healthcare and district hospital, but also there is expansion of midwifery lead care, and also we adapt the WHO recommendation antenatal care model in most of the hospital that provide service to pregnant women. However, the challenge, I see the challenge is not always policy design. It is implementation. There is a lot of policy that is designed, but on how the policy is implemented, that is the challenge is. There is persistent gaps, such as
Okay,
financial.
ma.
Hello?
Yeah, I can hear you. We can hear you.
I said that the policy is there, but the challenge is about the implementation of that policies to make sure that the
Yeah.
women.
But do you think that the government is not giving enough funding to the healthcare sector in this African country? That is what delays the implementation of this policy, or it is just poor governance?
Sometimes the fund is there, but it's not enough because, especially in rural area, there is a lot of people with the low economic status. So sometimes they need a lot of equipment that can make them favorable to receive the service without any complication. So I think it required a lot of financial support, but also equipment that can help during provision of services. So when we moving forward to policymaker, uh, uh, we must strike a balance between cultural sensitivity and evidence-based practice also. This require engagement community directly while we maintain clinical standard. But also we need to have advocate to make sure that from general awareness to have a general awareness campaign to more strategic is data driven engagement that directly influence policy decision. Sometimes when we are not involved the community in making decisions, sometimes we can decide things that is not reliable in current situation, but also we need to local government and the community leaders to play a crucial role in order to make sure that they shape how policies are understood, accepted, and implemented at the community level. Ultimately, we align global recommendations with local realities, require contextualization, prioritization, and the strong integration with primary healthcare services. That I think it will help a lot to make sure that these policies and the implementation of the policies are aligning well to improve the health of our mothers and children in the community. Thank you so much, Vivian.
Thank you so much, Madam Anita. Thank you so much for that answer. Miss Sarah, I would like to ask this question because you seem to be more in the field based off your marketplace antenatal startup setup rather. So I'd like to ask this question. What role do local governments and community leaders play in shaping how maternal health policies are accepted and implemented? Because for you, I understand that, and I think that when you were about to start that, you have to reach out to those people to be able to give you the permission to set up that in that place. Because I don't know if it's the same thing with every other places, but in Nigeria, before you set up something in the market, you will work out, you will do a lot. So I really want to know how that works for you. What role do you think the local government and community leader play in that aspect?
Yeah, Vivian, thank you so much. Same here. Before you do anything in Ghana, you go a cow. I think when it comes to African countries, we have a lot of things in common. Yeah.
Yeah.
But before I answer your question, I would want to add up to the earlier submissions from Kausa. So I am very much enthused and excited when I hear midwives talk about policy, they talk about implementation and being able to be in the boardrooms. But sometimes I feel like midwives get emotional about the conversation, which is rightly so because we see the problem and we feel we are left out. We are the ones that are supposed to be there. But the reality of the issue here is these people only understand data. Policymakers understand data. They understand what is working. They don't hear the emotions or feel the emotions. Sorry about that, but they understand data. So, as a midwife, we handle a lot of data. We are in the communities with the people, we are in the hospital, we have first hand experience with the people. How are we leveraging these information to influence policy? We don't need to get into those rooms before we talk about them. Like with platforms like this, it's advocacy. You may not know where it's going to get to. So when you are speaking as a midwife, you are speaking with facts. You are speaking with authority because you know what you are doing. So it's not just an emotional cry that we need to be in the boardroom in this and that. But as midwives, it's time for us to be knowledgeable. It's time for us to use the data that we have to influence the policy that we want to. And I think that with time, it is we are going to get there. In Ghana right now, we have a midwife who is part of the Ministry of Health committee. She's a midwife. She worked in the hospital for about 20 years, and now she's working with the ministry. So she oversees every policy implementation when it comes to midwifery. And trust me, we are seeing, even though it's not as fast as we want it to be, we are seeing the steady progress in the things that we want to see, right from midwifery practice training, right from the training institution, because when we talk about maternal mortality, it trickles down to the training institutions. So I think that midwives should be knowledgeable in their space. And I would also want to talk about the policies that have the exciting policies we have in Ghana. So in Ghana, just last month, we launched the primary healthcare, free primary healthcare. Even though we have the national health insurance for maternal healthcare, we launched the free primary healthcare for rural communities. I'm honestly excited about it because out of pocket expenses is one of the social determinants. Like it pushes people away from going to the hospital. I just pray that this policy will not fall flat like the other policies, that we are able to use it well, because when we are able to, it's going to help the people in the rural communities and the people that it's meant for.
Okay,
Roles, the role that, sorry,
can you? Sorry for
sorry.
interject. Can you hear me?
Yes, I can hear you.
Yeah, I was trying to talk to Sarah. Sorry for interjecting. Get this clear. We
Okay.
are practically learning from each other and see. Let's see what works, because in African culture we have to more like synergize. What works in one place, we implement it in that place. See how we can cover the gap. So I want to get I want to get clearly of what you just said. In Ghana, they set up a primary health care.
We have we've implemented a free primary health care. No, we've passed it. We are
Free,
yet to implement. Yes, we
a
are yet
free,
to implement it. Yes,
so
it's
no
been launched.
has been launched. It has not been implemented. And then
Yes, it's been launched. Yes,
okay,
but the whole idea. So sometimes when you listen to these people, the intention behind the policies they bring out is good, but I feel like the implementation. The reason there's a problem with the implementation is they don't co-design with the people that are involved. They have
that's it.
assumptions. They have assumptions that this is what is going to work. And I would say policy is just like business idea, bringing up a business. When you have a business, you don't assume for your customers that if I bring A, it's going to sell.
Your face.
Sorry, sorry, what do you
Then
say? Your line keeps breaking.
Can we
okay,
see your face?
Um, give me a minute.
All
Okay.
right, no problem. That's fine.
Yes. So the role of the local government and the the local assembly, right? We all have a role to play when it comes to making sure that the policy that is from up there works. But you see, when you go down there, they frustrate the hell out of you, and sometimes you want to give up on the work that you want to do freely for the people. I remember when I was starting this, so where I am, where we work at the Eastern region, it's an old train station area. I scouted the place and I realized that it has been abandoned, right? And it was a very good spot to to renovate into a clinic. And at that time, when I went there, the Ghana Health Service had already started something, but it wasn't really flying because the place wasn't conducive like that. It didn't even look like a clinic, but they had just put something there to represent something.
bring
So
people.
I had to see, yes, I had to see the assemblyman. I had to go to the regional health directorate, and the pushback I got was, in Africa, they would want to see the impact of the work before they give you their full support. So in the
Mm,
first year, I only had a verbal support from the Ministry of Health, no, the Ghana Health Service, and the assemblyman. So the assemblyman is more like the head of the community. So I just had a verbal partnership with them. And so after a year, they saw that now antenatal service has increased in the municipality. The market women are able to come for service and even sell, even in the clinic, because when they come, they get clients there and they sell whatever they have there. That was when they gave me the buy-in that okay, now you can come for us to have a formal partnership. So I would also use this opportunity to say that if you have an idea, you have to believe in it more than anyone around you because you have seen
mm,
the problem and you know how far it will go. The pushbacks will be there, but because you believe in it, that gives you the motivation to do what you are doing. So I'd say that
mm,
all of them have a role to play, but unfortunately, they want something from the work that you're doing. And I don't know the notion they have about NGOs. When you come in and you say you're an NGO, they would say that, hey, then you have a lot of money. How
Exactly.
yeah.
much are
Yes.
they giving you? Like,
Yes.
it's so heartbreaking. And sometimes it is just my money I'm using. Just 2 days ago, I went for an outreach and it was my funds. No,
Exactly.
but when I went to the facility and they had, oh, I'm a UNFPA, immediately, oh, you have to be coming often, you have to be doing that. And so sometimes they drain us dry
Yes, yes,
and
honestly.
we get stranded. But see, when we are able to partner together, it's very understandable that the government cannot oversee or do all the things that they want to do. And it's perfectly fine. But that's why we have some of us, the NGOs, the private sector, to do the
Mm.
things for them. So it is just great that we come together and partner and do the work that we have to do. But sometimes they will drain you dry.
Trust me, Sarah,
Thank
let
you
me say
so
something
much.
regarding that. Trust me, it takes a lot of effort. So there is one thing I do. Anytime we go into the community, I don't tell them we are an NGO because I've had this before. If in fact we are not an NGO to start with, Lock Natal Care is not an NGO. I introduce us as a social impact organization because they don't want to hear the word NGO. Once they hear the word NGO, I've gone to a community before and they start tasking us, oh, you have to bring so money, you have to drop so money. And I'm like, for goodness sake, we are here to care for the women. I am here to use my money.
Yeah.
We are here to use our combined resources. The our volunteers are here to give you their time, their effort, and everything. Why are you doing like this? Why are you demanding money from us? It took us more effort before we went to the primary care and the local government to get a letter and tell them that we didn't give these people money. These people came on their own will. They saw a problem. They want to help you with this problem in this community. That is why they are here. So it saddens my heart how these people just take others. Once you go into the community and tell them that, oh, you're an NGO and you want to do this, they look for every way to drain you. They look for every way to collect money from you. They look for ways to, it's just so sad. So anytime we go into the community, I tell them we're a social impact organization and our work here is to partner with you to ensure that we give the best maternal health services to these women and the rest of it. And they will just keep quiet after hearing that. As far as they don't hear that word NGO, they won't be triggered. But once they hear that word NGO, so many things, a million that's fly in their head, and then they are back to, tasking and the rest of it. So I just
I
wanted to add to
totally
that.
agree with
Thank you.
that. I totally agree with that. Because I've seen that.
I think
And
your
at the
mic
same
is
time,
muted, Vivian. Your mic is muted. We can't hear you.
can you hear me now? It wasn't muted. I think it's the
Yes,
network.
yes, I can hear you.
Okay. Yeah, I totally agree with that. Even though
Yes, you
I've
can go
seen
ahead.
that and I've seen the opposite
Oh,
side.
Anita said
Because
there's a bad network from my end, so the thing is shaking. I don't know what's happening from my
okay.
end. All right,
So
let's go ahead.
I have seen the good parts where
Vivian, I
community
can hear
leaders.
you. It seems
Yeah, she's talking. I think it's your network.
my network.
Yes,
Yeah, because
because I can hear
my
her.
mic is not
Oh,
muted.
really?
Can you hear me now, ma?
Maybe it's my
Yes, I can
network.
hear you.
You can hear
Okay.
her, right?
I when when
Yes, I
when
can
I
hear
was a
you.
student,
Oh
when
my
I went for
goodness,
my
it seems my
community
network. All right,
posting.
let her just go ahead. But you can hear me, Sarah. You can hear me. I can't hear
Yes, I can
Vivian.
hear you.
Nita, can you
I
hear
can
me?
hear both. I can hear
Yeah, I
both
can hear
you
you
and
too,
Vivian.
Miss Kauta. I can
Oh,
hear you, Mrs.
amazing.
Kauta.
Anita, please confirm you can hear me. Let me know where the problem is coming from. Maybe, all right, let me mute my mic.
Okay. I when I was a student, when we went for community posting, I saw firsthand how community leaders can help with this maternal and reproductive health. Because I remember then it was in a village, like a typical village. Days before immunization, the king sends their town crier to announce it the night before, then the morning before. So, and they always tell the women not to go to the farm and all that the day of the immunization or antenatal. And it was
Oh my
very
goodness.
like,
I can't
it
hear
was so,
Vivian. Vivian, I can't hear you. I don't know why.
I think it's the network. But every other person can hear me, right?
Yeah.
Yeah, I think she has to leave to join back because I think that's her network. And it was so interesting because having that seeing that willingness to make sure, maybe because the king was educated. I don't know if that was a factor. Maybe the king was,
Now I
because the
can't
king
hear
was.
Vivian.
Oh wow.
Can you hear me
Can you
now?
hear me now?
I can't hear anyone.
You can't hear anyone?
Can you hear me now, ma? Can you hear me, ma? Miss Kauta, can you hear me, ma? I don't think she can hear me.
Can you hear me now? Please
Yes,
confirm you
ma.
can hear me. Oh my goodness. I don't know why they can't hear me.
Can you hear me, ma?
All right. Sarah, welcome back. Can you hear me?
I think the network
Yes, I
has
can
gone
hear
off.
you.
Sarah, are you there?
Yes. Yes, I can hear you.
You can hear me, right?
Yes. Can you
Yes, you
hear
can hear
me?
me. Thank you. Thank you. But I can't hear you, Sarah. I can only see your head. You're nodding. I don't know what's happening. Oh my goodness. This shouldn't be happening now. I mean, we are like middle into the conversation. We shouldn't be having this now. I don't know where the problem is coming from. And I don't want to end this live. Oof. Okay, Vivian. Vivian, can you hear me now? Is it better? Vivian, are you there?
Can you hear me?
Okay. Let me join directly from
Vivian,
YouTube
can you
then.
hear me? No, Vivian,
Oh
I can't hear you.
goodness. Oh goodness. This is the challenge with this thing. Ah, I don't know if I'm the only one here. Oh my goodness. Okay. Hold on.
Can you hear me now, ma?
Yes, Vivian, I can.
Okay.
Okay. All right. Welcome back. Welcome back. I don't
I
know why the
think the
network is
network
messing up with us. Please go ahead.
is bad. I don't know why.
All right,
Um.
Vivian, please go ahead.
Okay, we can hear.
So I
Can
think the
everybody hear
network
me
dropped us a
now?
bit. So sorry about that. Please go ahead.
Can anyone hear me?
Yes, we can hear you. Can you hear me?
Yes, I can hear you.
All right. So,
Oh my goodness.
I said I've witnessed the both sides where the community leaders are involved and where the community leaders are not involved. Where I did my community posting when I was a student, the king ordered the women not to go to farm on every antenatal day, so they don't go to farm. And immunization days for those that have children, they don't go to farm. So the night before the antenatal day or immunization day, they send their town crier to go and announce it that, oh, everybody must come to the village, to the clinic, the primary health center for this, that, and all that. The morning of that day, they do the same thing, and you'll be shocked at the turn up of these women when they already have an order from their king that, oh, on so day, if you know you're pregnant, we don't want to see you in the farm, go to the clinic, or go to the clinic before you go to the farm, and all that and all that. So it's a really, really good thing when the community is involved with this implementation. So, Miss Anita, I would like to ask you this question. Can you hear me, ma?
Yes, continue.
All right, thank you so much. You do basically digital, your work is mostly digital. So I would like to ask, how can innovative care models like um webinars and online antenatal services be scaled effectively?
Pardon, please.
I said, how can innovative care models like online antenatal services or maternal services and maybe women's health webinars and all that, how can they be scaled effectively? Did you get that, ma?
Yes, I believe that, and I think this online webinar, this innovative, this interaction of maybe the women themselves or with the healthcare provider as a midwife, nurses or doctor can help first of all to understand different perspective of the women health, but also it can help us to share experience on maybe on Tanzania when we face a challenge about the maternal health. We are dealing maybe 1, 2, 3, and maybe Ghana they solve the same situation by using the formula 1, 2, 3. So this help us to increase our knowledge when we share experience, so that it can lead us to improve the provision of care to women, because all we want is to make sure that the maternal health is given important aspect, so that we can reduce or remove mortality and morbidity of these women that we serve.
Thank
Yes,
you so much, ma.
thank you.
Thank you so much for that answer. Mrs. Kauta, are you with us? Mrs. Kauta, are you with us? I don't think she can hear us. I don't think she can hear us. Hello, Mrs. Kauta. Okay, Ma Anita. I would still love to ask these questions. What role do midwives and frontline healthcare workers play in driving sustainable change within maternal health systems? Did you get that? Did you get that, Ma?
Yeah, you ask about the role of the midwife, right?
Did you get that, Ma?
Hello, Vivian. You ask about the role of the midwife in the community or in the healthcare facility.
What role do midwives and frontline healthcare workers play in driving sustainable changes within maternal health systems?
I believe that a midwife have an important role to make sure that they drive maternal health changes because we are the first one who are providing care to women throughout the process of giving birth. When they find pregnant during preconception, we provide service, we provide educations, and when they start antenatal clinics, we are there to make sure that the women health is sorry. And I said that during antenatal, we are there to make sure that the women is receiving holistic care. He's receiving all the checkup, investigation that is needed in order to prevent them from getting morbidity during pregnant. But also, we have important role to make sure that during birth, we are there to make sure that the woman is giving birth in a in a in a manner that there is no complication, and if complication occur, we solve it so that we can improve the health of these women and their baby. But also our role is on postpartum period, and most of the time sometimes we forget this period. We make closeness much during pregnancy with these women, but when they're giving birth, we think these women they know each and everything, they can cope up with postnatal period. But this period, I observe that there is very important of the midwife to be close with these women because there is a challenge of breastfeeding. The mothers can fast, breast engorgement, mastitis. So when there is no midwife who can guide the way through this breastfeeding journey, the mothers can fail to successfully exclusive
All right.
breastfeeding.
Thank you so much.
Yes.
Thank you so much, Ma.
Okay. Thank you.
Thank you
All
so
right.
much, Ma. So, Miss Kauta, you're with us now. Miss
Yes, I
Sarah.
am. I had to
Miss
join with
Sarah, can you
another.
hear us now?
Okay, to
Yes, I
type.
can hear you. Can you hear me?
All right. Yes, we can hear you loud and clear. So, Ms. Kausa, I would love to ask this question. You do more of community-based outreaches and um yeah, outreaches basically. So how can community-based initiatives and healthcare systems work together to address maternal health inequalities?
All right, so thank you for that question. When it comes to community health and the healthcare system, I think that's a core of what we are doing at Long Natal Care. We are not
Yeah.
separating, do not want to separate it because one way or the other, both of them need each other. For example, majority of our women that we have in the community, there are times that we see high risk patients. When I mean high risk women, women that have preeclampsia, I mean severe preeclampsia, that they don't even know. They think it's just, I mean, my leg is swollen or this or that. They could not recognize that preeclampsia. the people in the healthcare system, I mean, those that are, I'm also a clinical midwife, but when I'm in the community, I don't wear the jacket of clinical midwife. I wear the jacket of, I'm an advocate, right? I'm an entrepreneur. This is what I'm doing at this point. And at that point, we cannot separate both the community care and the care they receive in the healthcare system. So when we are talking to the healthcare system, when we are reaching out, when we are extending our arms, we are telling them that we are extending an arm of partnership. Because when we have women who are high risk, when we have women that we need them to go to somewhere immediately, it is you they will still fall back on. And that is
Yeah.
why the things we also do at Lock Natal Care, one of our projects we also do is training the healthcare providers, training the, we have TBAs, that's traditional birth attendants, training the healthcare workers, training the community midwives, training the, we call some people choose. I don't know if that's the name they call it in other countries. That's community health extension workers, so that these people can know what they are doing. These people should be able to identify when there is a complication. These people should be able to manage certain women. I mean, should be able to manage, let's say, pregnancy and childbearing, should be able to identify a complication on time. So yes, there is no way we differentiate both of them, or there is no way, let me say, not differentiate, there is no way we marginalize both. We have to work in synergy with them. And it has been going well, right? We work in synergy with them. We refer our women that we see in the communities that are having one issue or the other, we refer them to the healthcare, right? And also, one of the things we are doing is to ensure that 70% of the women we see in the community, they have a safe and sterilized birth at the primary health care, because most times they don't do that. A lot of times, most of them have their birth in someone in the community, someone who is, let's say, a grandma, someone they have known for a longer period of time, a grandma or a older woman in the community, they birth their babies there rather than going to the healthcare facility. And that is where some of the challenges are coming from. Unsterilized birth, sepsis, and the rest of it. So we can't separate the both. We work in synergy, both in the
Yeah.
community and those in the healthcare system. A referral for continuity of care, and also for them to also know that these women are in their community and they have to take care of them right. So yes, we can't separate them. We'll bring them together. It's a priority.
Thank you so much, Ma. Thank you so much for that answer. Because whether we like it or not, community-based initiatives are still pioneered by healthcare workers, whether we like it or not, because they understand the effect of these initiatives in rural communities. Even though they might not be working there, but with their experience, with even in urban areas, we still experience these issues. Talk talk more of rural areas. So it's already interwoven, and it just needs a good interpersonal relationship between the two teams to bring a perfect job done. So, Miss Sarah, I would like to ask you this question. Can you hear me, Ma?
Yes, Vivian, I can hear you.
Okay. So the question is still on the partnership, because now we are talking about implementation and action on how to bring forward this maternal and reproductive health to women in underserved communities. So how can partnerships between public, private, and community sectors improve maternal health outcomes at scale, like at a larger scale?
Sorry, can you come again?
I said, how can partnerships between public, private, and community sectors improve maternal health outcomes at scale?
Yes, so I think that when I was giving my earlier submission, I mentioned that no, the governments will have their policies, they would have their ideas, but it is the private sectors and the community-based organizations that actually implement these things for the government. So I think it will just be fair that um all community organization, youth-led organization, midwife-led organizations, individuals that have are working towards maternal health come together. I think that we've also not been able to solve the issues of maternal mortality largely because organizations are working in silos. I don't know if each person would want to take the accolade, or sometimes you really sit and you want to understand the motive behind what these people are doing. And I feel it's one reason why we've not been able to achieve what we want to, where we want to get to. If we can all, as community-based organizations, working towards maternal health, or with one goal of reducing maternal mortality, if we can all come together as a body and fight towards it, we would have a greater voice in the first place, and we would be able to push even the work that we are doing into the government spaces for our work to be heard, or the things that we are doing to be heard. Because if just me talk to your midwife would want to go to parliament or to go to the minister and say that, oh, we've been able to increase antenatal uptake in the municipality by 3%. Okay, so it is just one municipality you worked at. But I'm sure there's someone somewhere who has worked in another region. If we are coming together with all our data, all the
Mm,
findings that we've been able to come up with, it will hold ground, like it will hold water. That's how I'm going to say
yeah.
it will hold water. So that you are able to really speak to it. For just talk to your midwife, it's going to take a while for us to be able to get to that point of influencing the policy, which one day we are going to get, but it's going to take time. So I would say that all these organizations should come together as a unified body to fight for the common goal that we have. Then the government can trust us. That is it. Because now people also have their own motive for starting NGOs, because for some they
All
think
right. Thank you
there's
so
a lot
much.
of money in it.
Thank you.
Sorry?
Yeah, I said
Hello?
we lost you for a second. We lost you for a
Ah,
second
so
there.
I was saying that if we can all come together as private organizations or NGOs coming together, then we can all have a partnership. The government cannot come and partner with just my organization and say that, oh,
Yeah.
we've seen the work that you're. It is possible, but on a scale of 1 to 10, like it's 3. Do you get it? But if we have a consortium, we have 3, 4, 5 community-based organization coming together as one body, the government
Thank
can
you.
easily partner with us for us to be able to push their agenda for them. Yeah.
Thank you so much. I totally agree with that. Thank you so much. Um, so now I'll be moving to the next section. Um, I think I would like Mrs. Kauta to answer the first question in this next section for us. So
Go ahead.
I understand that there is significant brain drain. I don't know if it's affecting other countries as well, but in Nigeria, the brain drain is serious. Eh,
Something.
it choke. That in our language, it choke. Because I remember I graduated some few years ago, and I can tell you that majority of my classmates, even the ones that are in Nigeria, they are planning
Okay.
to japa.
Yes, Canada, whatever,
Like
Saudi Arabia.
everybody is just moving. The next thing you are seeing, oh, welcome to a new dispensation. Welcome to a new everybody is moving.
Everybody is
So
dispensing.
everybody is moving. So the brain drain is serious. So the question is, how can we address the shortage of skilled healthcare providers? Because even the ones that we have, they are not willing to go to the rural areas to work.
Honestly.
Everybody wants to Everybody wants to work in FMC, everybody wants to work with Shell, everybody wants to work in ACME, everybody
Honestly.
wants to be in big hospital. So that they will not ask you where are you working? You not say you are working in Jalingo or something. Nobody wants to be there. Nobody wants to be there. Everybody wants to work in a high profile organization so that they will know me. Ah, at least I'm a big girl, I'm a big nurse. They know me in my organization and all that. So how can we address the shortage of skilled healthcare providers in rural and hard to reach areas?
Hmm. Honestly, that's a big question. I'm sure that for those that are on this call, they're also midwives. Everybody is midwives here. I'm sure that you attest to the fact that when it comes to African countries, there's a lot of brain drain, especially when it comes to midwifery practices, when it comes to midwives. Now, if you look at the statistics, the number of midwives that we have in Nigeria is not equivalent to the number of women that we have in Nigeria. It's too much. The gap is too wide. Let's say there is one midwife to, let me use the statistics of 30 women, if not more.
Yeah,
It's that crazy. Now, think about it. If you, as a midwife, you also have other things that you're doing with your life, you also have other aspirations and the rest of it. And now everywhere is choking, everywhere is, you're a midwife attending to, even in the hospital. I still work in a clinical settings, even aside running my non-for-profit organization, right? And anytime they bring in women, it's like back to back for us. Sometimes in your shifts, you don't get to sit down. As they bring one woman, you attend to her. As you're preparing for labor, there's another woman that is in labor, there's another woman that is in labor, and you barely even sit throughout your shifts. Like from one woman to the other, it's crazy. So how can we retain? Honestly, I would say it's not as if I can answer that question, but what I would say is for we that were available, because I can't speak for those that have gone. Everybody has a reason for leaving the country, everybody has a
yeah,
reason. One old people, everybody wants to do better for themselves, they want to do better for their lives, they want to see greener pasture and the rest of it. And those that are not seeking greener pasture, those that want to work in high profile organization and the rest of it, we can't blame people and we can't make decisions for people.
yeah,
However, based on what I see a lot and what we that we are there, what we can do. For example, I didn't just decide to start Love Natal Care because I wanted to start. I started because when I was pregnant in 2021, imagine a pregnant woman, someone like me who is pregnant and having to see another woman almost lost her life. And in that moment, I kept thinking, if this could happen to someone in my front, it mean it could happen to me. I was already a midwife then, right? Like way before that, I was already a midwife. But they say sometimes when some things aren't done on you, you won't realize the core problem that you're facing. So at that
until it
point,
hits
I
close
went
to home.
exactly until he close to home. So that one hit close to home, home. Do you understand? That one hit
Yeah,
there because being in communities and I've seen women die. I've seen them taking delivery and women die due to one reason or the other, women die. But I didn't feel it so personal until that one hit close to home. And I'm like, I am pregnant as well. Do you think, oh, does it mean anything that can happen to me as well? So I kept thinking and thinking and thinking. And that was when I said, you know what? Instead of complaining or waiting for orders or waiting for the government, I think this is the high time for me to wear this shoe and start this organization. And that was how Love Natal Care was bettered. Trust me, just like what Sarah was saying, it's not easy. It takes a lot of effort, a lot of resources, a lot of funding, a whole lot of funding, a whole
yeah,
lot. I mean, more money and the rest of it to run projects, to keep it going, to ensure that these women have this access, to ensure that these women have this awareness, they have this information, they have this knowledge, to ensure that we extract the statistics. So when it comes to how can we balance the brain drain, trust me, I can't say much on rebalancing the brain drain. The only thing I can say is we that we are available, that we are committed to the work. I pray God give us more strength, and I pray that more organizations spring up to see how we can do this work together. Just like Sarah, trust me, we can't do this alone. Myself, I can't do it alone in Nigeria. Sarah cannot do it alone in Ghana. Mata cannot do it alone in Cameroon. Anita cannot do it alone in Tanzania. We need more real change makers to sit up, to spring up and say, okay, we are all here to do something regarding maternal health, right? And once we are able to do that, we should identify ourselves, form a coalition, and talk as an organization in which we can pouch the government and say, you know what, we are a group of organization and this is what we are doing. We want you to put us in this position. We want you to consider us, or we want you to listen to us. This is the statistics and the rest of it. So that way we can do more work. But saying, how can we talk on the brain drain? Honestly speaking, honestly, I can't really say much because everybody has their reason for leaving and going and going. But we that were here, I pray God give us the strength to keep doing the work. And I pray that more sincere organizations, social impact organizations, community-based organizations spring up to attend to the needs of mother and children.
All right,
Yeah.
thank you so much. Thank you so much for that answer. So, Miss Anita, I would like to ask you this question because you do more of digital outreaches. So, what roles can technology play in improving maternal and reproductive health access and outcomes? Now we have AI and Chat GPT,
GPT, Gen
Cloud, Gen AI, everything AI. So and I've seen one importance of AI because where I worked for internship, we used EMR and trust me, it's easier than paper. It's far better and stress-free, and anything you want to do, you put it in the scanner and upload to the system, and it just flows, it goes. So I really want to know, like, in midwifery, in maternal and reproductive health, how does this improve the access and how does this help us to get an improved outcome?
Hello, Vivian. I didn't
Yes,
hear you.
ma.
I didn't hear you well. Sorry.
Can you hear me, ma?
Now I can hear you.
Okay, so I said the question is, what role can technology play in improving maternal and reproductive health access and outcomes?
Okay, I think she's in, what would I say, a noisy environment or so.
Yeah, I think so.
All right, just go ahead with the next person. I think we should be rounding
Okay.
up.
Um, my Mrs. Sarah. So under postpartum care, you spoke about postpartum care earlier. I still believe that postpartum care is under prioritized. So why, my question is, why is this still under prioritized? Because most people, when they, I remember when I had a friend that gave birth and she was tilting towards postpartum depression. She didn't have any complication after birth or anything during birth and everything, but she was tilting towards postpartum depression. But because we were all like healthcare professional, because she gave birth and she resumed classes few months later, and you notice that every time she's always giving you to her child to carry. She's always tired. She's always, don't worry, carry the baby. Oh, don't worry, just feed, the food is in the bottle, feed him now. Don't, like, she's having this apathy towards the child and all that. So why does this still feel under prioritized, and what risk does this create for the mother?
Okay. Um, I, I didn't talk about postpartum, but it's fine. I'm a midwife, so yeah, can definitely talk about it. So I believe strongly that you see the way our healthcare system is designed, right? It's designed to be focused on delivery. So delivery is more of the end point. And once the woman gives birth, it's assumed that she is fine, and attention goes to the baby. Even look at our setting in our homes when a woman gives birth and we are coming in to um, say hello. Everyone comes with gifts for the baby. No one comes with gifts for the mother. We
Yeah.
think or we assume that, oh, the mother should be fine. It's the baby that is the visitor. So we need to treat the visitor well. That's
Whereas
the
it's
assumption.
the
But
mother that we've known. We don't know the baby.
you
The baby
know,
is a
you know,
stranger.
that's when this loyalty started. You see, but I think it's high time that we focus on the mother too, because see, this woman has not been in that position before. We treat women as though motherhood comes with a manual, that
Mm.
they should know how to go about their motherhood. But see, it doesn't come with any manual. Everyone is trying to figure it out by herself. They don't know what to do. And see, sometimes your body changes so much that you begin to question yourself that, is this me? Now you don't even notice who you are. You don't feel confident in your body. You go through all these changes, and after you give birth, everyone's attention is on the baby and not you. How will you feel? Did you get it? And so there's low awareness of postpartum risk as well, like from hemorrhage to mental health challenges, and fewer structured follow-up systems to keep women engaged after delivery. Do you get it? Now, when you give birth, even though there is the postpartum care, that the first 24 hours you'll be checked, you have to come back in the, I think, 1 week after, then 6 weeks, that's 40 days. After that, you're on your own. But ideally, the community health worker, that is why they are there, they should be able to conduct periodic home visits. They should go for periodic home visits to check on these women. So in reality, the postpartum period is one of the most vulnerable times for women, but it remains one of the least supported areas for them, because awareness and education is not really around it. It's just about antenatal and childbirth, and that is all. So if look natal, talk to your midwife can also channel the energy we have for antenatal. I think it's also because we have that drive for antenatal, because that is the beginning of the whole journey. If right
Yeah.
from antenatal, the woman has enough knowledge,
Yeah.
gets the right care that she
Yeah.
needs, postpartum should really be easy for her. So yeah,
Yeah. So I think, yeah, I get your point, Sarah. Can you hear me?
yes, yes, you can hear you.
Yeah, I think, postpartum, no, sorry, antenatal is like the first step. And
Mm-hmm.
antenatal is one of the
Yes,
causes
we
of
can hear
maternal.
you, ma.
If the woman does not have the knowledge, she doesn't have the information, she doesn't have the right care, I think that is where we kind of have, over time, or let me say over the years, that is where we have more complications stemming from. But as it is now, a lot of complications are now stemming from postpartum care now too. So I
Yes.
think we want to include it more in we are starting some of our projects very soon by next month. As a matter of fact, we are even doing more community entry tomorrow. So when we are planning our project, I think we need to also put that into consideration to see how we
Mm,
can do a lot of follow-up visits to our women, right? I think we need to be intentional about that. And I think you should do the same as well because it's
sure.
very, very important so that we don't get a lot of women having postpartum blues, having postpartum depression, and the rest of it.
Mm,
So, yeah, thank you for mentioning that.
All right. Thank you so much, ma, for that. Thank you, Miss Sarah. Thank you, Mrs. Kauta. Miss Anita, can you hear us?
Sorry, let me say something before I go to
Okay, ma.
Sarah. Do you know that, Sarah? Do you know that when I had my baby, I had the same encounter?
mm. Really?
Yeah, I had the same encounter right from the hospital. I had my baby, and immediately I had my baby. Mine was even that bad. Immediately I had my baby, they were all my colleagues. They left me on the couch and they all went to the baby. Oh, your baby is beautiful. Yes, I was so pissed. Honestly, it's not okay. We can laugh over it now. We can laugh about it now. But then I was
Yeah.
so because you gave me what is it called? I had an episiotomy.
Episiotomy.
Yes, the midwife gave me an episiotomy. I had my episiotomy there. You had not stitched me. The next thing you did was remove your glove and start touching my baby. Oh, the baby is so beautiful. Oh, the baby is this, the baby is that. And I was like, what is going on? Won't anybody stitch me up? I need to stand up from this car. I started getting angry, and then they all came back to me and said, "Oh, we are so sorry. We're trying to greet your baby," and the rest of it. So a lot of times, yes, like you said, the attention shifts from the mother to the baby, and people don't consider the mother again. Nobody cares about how are you doing. Nobody cares. Not knowing that postpartum is where the bigger challenge is. A lot of women, because of the stress in pregnancy, because of all the issues you must have had, a lot of women pile up a lot of things. And then in postpartum, it start coming out one after the other, one after the other. If there is nobody that is there to care for that woman, there's nobody to there to say, oh, I'm here for you, trust me. Then the woman can go into mental health condition. And then we keep saying over and over, why is mental health condition on the rise? These are some of the reasons. So I think we too, we have certain work to do. Yes, they didn't do it for me, but I had a lot of support when I got home. I mean, from the hospital, after I shouted and the rest of it, when I got home, I had a lot of support. Maybe because I was like, I need this support. Everybody must be around me. I asked for it and I got it. A lot of women don't get to ask for it. They just feel like someone should give it to them. And when nobody gives it to them, it is just there. Do you understand? So I think we need to double our efforts and also do more, and then we can get more women to get more access during postpartum care as well. Thank you. I just wanted to chip in
Right.
that.
Thank you so much. I think midwife Anita can add her voice to, because her work is more on postpartum, and
Yes.
maybe she's seen stories. She has stories and experiences that can help us.
Hello, Manita. Are you with us, ma? Can you hear us now?
Yes, I can hear you.
Okay, so we were asking you a question earlier. So,
Uh, ask about the using of AI in
yeah, we
improving.
were asking if we were asking what role can technology play in improving maternal and reproductive health access and outcomes?
Okay. Artificial intelligence and digital technology can have a significant potential to strengthening maternal and health system. As we can see nowadays, it helps us especially in improving access, quality, and
Yeah.
continuity of care. There are some hospitals using AI to allow pregnant women to ask questions and receive immediate response. But also from a system perspective, one key rule of AI we can see is it helps us in error risk identification. I see last 2 weeks I use Ministry of Health of Tanzania. They have the numbers that women can ask a question in through WhatsApp, and there is a cartoon or there is a people who are having igizo. So when you ask something, you receive information which help you to understand the situation you have and it help you to get the solution. But secondly, the AI, this technology improve continuity of care through digital tracking of antenatal and postnatal visit. It helps reduce the loss of follow-up, particularly in the critical period like postpartum period. So the women can make a follow up through this platform. But also it supports decision making for frontline health workers, especially in the area where there is low resource setting, by providing clinical guidance and the standardized protocol. And in addition, mobile health platform can help to expand health education and patient engagement. As I use Instagram teaching, so I see health education. When I provide health education there, most of the people they receive this education at the same times, and they it helped them to change behavior. It helped them to get uh, accurate information, but also it help in impact at scale. This technology sometimes must be designed to be accessible, context specific, and integrated into existing healthcare system, because not all all people they have courage of going into the health facility to ask questions. But when there is if each hospital or if there is a lot of midwife having the platform that they can make pregnant women, their families, easy access, and they can ask questions, it can help to make sure that information about the health changing behavior, it is easy to be accessible to every person in the community.
All right, thank you so much, Ma. Thank you so much. We really appreciate. We're about wrapping up now.
Sorry,
Madam Ma.
I wanted to add something. Yeah.
Okay.
Yes, technology can help when it comes to advocacy and when it comes to, let's say, using storytelling to spread our work, right? Let me use that word, advocacy, spread our work. For example, what's it called? What Anita is doing with her social media, she's trying to get more people. A lot of people in and outside Tanzania can easily, when they have a phone and they have data, they can easily come into our Instagram to see how she's providing healthcare services for women and the rest of it. However, when we look at that, yes, technology is a good way that helps majority of women and the rest of it. But when we look at it from another angle, it is not every woman that have access to technology. For
Yeah.
example, at Lock Natal Care, we also have our, I'm sure Vivian is aware, we have our pregnancy and delivery support community on WhatsApp. So we have two communities on WhatsApp that is about over 1,500 women, right? Now, in those communities, in our community on WhatsApp, we are only able to access women that have for as little as WhatsApp. If you don't have WhatsApp, majority of our women, if you go to our community, most of them will tell you, oh, they're not on Instagram, they're not on Facebook, they're not on this. They only access WhatsApp. So, in as much as technology is good, right? Majority 70% of women do not access technology. Is either they don't have the phone to make use of those technology, or they don't have data, or they don't have any resources else they need to access the information online. So most of them, the only places where they get their information and knowledge is when someone bring the service to them, or if the primary health care where they are in their facility, in their vicinity, if it's proactive, that is the only time they get to get this maternal and reproductive health services. But outside that, 70% of, or let me say 60% of women that really have issues when it comes to maternal health services, they do not have access to social media or technology. However, yes, technology still plays a big role. Either we want it or we don't want it. Technology still plays a big role in advocacy and getting more people and telling our story to get more people to relate with what we do. I just wanted to so that is why we can't do it in silos. We have to use both the technology and our community driven project. Do you understand? We have to do the community driven project to cover those that we can't cover on the social media and the rest of it. And then we use our technology to share our story, to talk about it, and then get those that can join from online too, so that we can get more coverage for more women.
All right, thank you so much, Ma. Speaking on community, I understand, I know about our online communities for pregnancy and delivery support. So having that community, it still boils down to I think health education and health accessibility. How do you ensure that maternal health education is not just accessible, but it is implemented? Like the women that get this education, they know what to do with the information. This includes sharing to other women, because trust me, if there's any form of communication that can never go off, it's word of mouth. Technology or no technology, what mama Mrs. So so and so, there's something I learned on our PDS group today. Oh, they said that mother should do this, mother should do that, mother should not do this, mother should not do that. And at the end of the day, that one tries it and she gets a good result. Oh, and she tells her friend and she tells her friend, and it goes on and on and on like that. So how do we ensure that this maternal health education is not just accessible, but they are being implemented and acted upon by these women that have access to them?
Okay, so one of the strategy we use at Lock Natal Care is will involve them. See, there is one thing that if you don't involve women, you are just going to talk and talk and talk and talk. They won't implement whatever it is to be done. But when you involve them, when you get them to be part of it, they become part of it. They give you ideas. They strategize with you. They have a feeling of, oh, I'm part of this thing. With that, it becomes easy for them to implement. For example, when we wanted to do International Women's Day, we compile a video. We make it like every year. We compile a video for International Women's Day. Trust me, for that International Women's Day that we did, you would see that a lot of our women participated. Immediately, I went to the community and I said that, oh, we want to do a video for International Women's Day, women that have challenge and wish to share their story. We want to hear from you. We had a lot of people that come on. We could decide not to involve them. We could just decide to say, okay, we pick the healthcare workers, we just do our own thing and just put it out there, right? And then when they see the information, what do? They consume the information as usual without doing anything. But because we involve them, we've tested it that when you involve women, when you're designing something, either a project or you are designing whatever, a problem and everything, they get excited. Not only they get excited, they feel among like, oh, this one is our thing, this one is our problem. How can we solve it? How can I tell another woman beside me? How can I involve another woman? And from there, they get to do it, they get to implement it. So when we mentioned that, a lot of them came out, they were super excited, they wanted to share their story, and we gave them that leverage. Okay, share your story, we'll put it on social media. Tell your family and friends to go and watch you on our social media. They were excited. So, and I think it also that same strategy can go well with the community. That's one of the things that's one of the strategies we also use in our community. When we get to Love Natal Care in the community, when we get to Lock Natal Care communities and all that, we try to also involve the women. For any project we want to do, for any design we want to do, we try to call the women, okay, this is the problem affecting you. We need you to bring your voices. We need you to lend your voices. And when they start talking one after the other, by the time each and every one of them start talking, before you know, we get a lot of ideas, we get a lot of implementation. Implementation does not even become hard for us because they're already involved. By the time they start to implement it for us too. They start to tell us, okay, they even start to give us ideas and say, okay, this is how better we can implement it. So when you involve women, implementation become easy and not just talking over and over again. So implementation become easy when you involve women. Involve them, and trust me, you would get a lot of implementation. Then hear their perspective, listen to their perspective. Don't just think, for example, when we are designing our project, we don't just think we know it all. For example, me personally, I don't think I know it all. I'll just sit down. Okay, I want to hear from you guys. Give me your ideas, give me your thoughts, give me what you think. Trust me, someone might bring a very brilliant idea that I am not even thinking of. So that goes a long way for me. So for women as well, more than just awareness. When we involve the women, when we hear their perspective, when we listen to them, when we get them involved, implementation becomes easier. Or don't you think so, Anita and Sarah? I mean, that's a strategy that we use.
Thank you so much, Ma, for that. Thank you so much, Ma. Miss Sarah, I don't know why I keep saying Mrs. though. Miss Sarah, this question, can you hear me, Ma? Miss Sarah, are you here?
Okay.
Okay.
She,
Miss Anita.
okay, Sarah is a call. All right.
Okay. Miss Anita. So this next question, I think we're wrapping up now. This should just be the final question for you, Ma. Um, you've supported over 8,600 mothers. What patterns have you observed in postpartum complication that could be prevented with better systems?
Oh, thank you so much. Do you hear me?
Hello, Ma.
Yes, we can hear you.
Okay. Thank you so much for a great question. From my
Yes, Ma.
experience, one of the most important I have observed is the postpartum complication that's often postpartum complication most of the time are not occur due to lack of initial care, but I observe that most of the postpartum complication occur due to the gaps of follow-up system. We can see there is a high risk of the women which faces after giving birth within the first 48 hours. This period, most of the women that face most of the complications such as postpartum hemorrhage and infections, most of them are having um also, they face breastfeeding related conditions such as breast engorgement, and others they face mastitis, and also others they face a challenge of unaddressed maternal mental health challenges. Most of the women experience baby blues, and sometimes they develop to uh, postpartum depression, and no one care about the women after giving birth at home. And sometimes when women show the sign of maybe mental health problem, families they say that maybe the women are acting, maybe the women need attention but she's not sick. So there is a lot of complication that women they face, uh, and the critical things is the critical things that I observed here is that this most of the complications that occur during postpartum period are preventable. And however, um, once the women deliver, the continuity of care declines significantly. Most of them they don't know the importance of returning back for postpartum checkup, and at the same time, the few of them who are returning back to healthcare facility, when they are there, a midwife or nurse who attend that client, sometimes due to a lot of activities, maybe you can find there is a one midwife who taking care of all postpartum care, antenatal care, those who have coming for family planning. So sometimes there is there is no specific checkup that these women are going to be observed. So sometimes the mother is going there for postpartum checkup, but she didn't see if there is important checkup. She's being addressed. She's being taken to her. She's not asking any question about her mental health status. So sometimes they don't see the importance of coming back to healthcare facility for checkup. And the major three system gap that I observe, the first one, there is weak implementation of structured postnatal care schedule, as I said. They returning back, but there is no a specific checkup, maybe, or there is no specific maybe guideline that the hospital having so to follow it when the mother is returning back. But also the second gap, I see there is a limited follow-up at the community level. And when the mother is giving birth, especially those who are giving birth at home, they returning at home until 42 days, and then they returning back health facility for starting vaccination. But we miss the follow-up to make sure that everything is going well since she gave birth. And the third gap, I see insufficient education for mothers on recognizing danger sign, the early sign of the danger sign. The mother herself didn't understand the danger sign, and the family member, the mothers who taking care of this postpartum mother, they don't recognize early the danger sign, so that they delay to take action to returning back to health facility. According to WHO recommendation, we see that postnatal care should begin within 24 to 48 hours after giving birth, then if by additional contact in the first 2 weeks and at the 6 weeks. Uh, if we strengthening this continuum, especially early postpartum follow-up, we can significantly reduce preventable maternal and newborn complications. In this area, I see it needs urgent system level attention. So when the healthcare provider, when the midwife are there in postnatal checkup, they are supposed to have a guideline that guide them through the healthcare facility level, uh, to help them when a mother returning after 48 hours, maybe or 3 to 7 days after giving birth. What investigation should the mother receive, rather than to telling the women to coming back into the health facility, and then we only asking, how are you? The baby is breastfeeding. When the mother is saying yes, okay, we say that you can go back home and then coming again after 21 days. So if we have a checklist that guide us to make sure that every aspect of the women health is monitored during the checkup, we can prevent this postnatal complication, and the women they can returning back, and we as a healthcare provider we can collect data, and also it can help us to reduce the complication effectively. Thank you so much.
Thank you so much, Ma. Thank you so much. Thank you so much. Like that was insightful. Thank you so much. So, Miss Sarah, are you here now?
No, no, no. Sarah is not on the call. She's having some glitches and the rest.
Okay.
Yeah.
I don't know if we have any question from our audience. I'm checking the chat box. If you have any question, you can quickly drop your questions. Our speakers can quickly address them. We'll be taking the first two because of time.
Okay,
If you
so
have any question,
we have some comments in the chat box. I don't know if you're seeing it.
yeah.
Okay.
Arinola Doka said, I think she's speaking about the when we spoke about challenges of accessibility. She said for some people a distance within 5 kilometer radius is still a challenge to them. But that I think with that it does not, the onus is no longer on the health professional or on the um people in the community that are serving this community. This now falls back on the individual's willingness to participate in whatever initiative going on in your community. That, like they say, you can force the horse to the river, but you
But you
cannot force the
can't
horse,
water exactly.
you can't force it to drink. So I think that still lies. It's understandable when it's quite a distance, and you can say that, oh yeah, it's a distance, and it's obvious that it's a distance. But when you try to use a little walkable, like 10, something that is like a 10-minute walk that you can even use as an exercise, or 15-minute walk, and you are
Mm,
saying it's a distance, I mean, that's now the ball is in your court, right?
yeah, I
Then
agree with you.
yeah, I see religion. Okay, she said she's when I think this was when we were speaking about the things that the barriers, as much as we say okay, cultural diversity affects the implementation of these maternal and reproductive health education and rights, religion also some in some religion they say, oh, the husband is the head of the house, everybody knows that. Say, oh, you must not take a decision without telling your husband. In even that's why most of the time we have situations where women that have taken that are supposed to have participated or done family planning, they don't do it because their husband can tell them, oh, I don't want to do it. Oh, let's use the natural method, or let's do this. We don't want any, don't put anything in your body and all that. And they end up giving birth to 6, 7, 8 children.
or even more, with complications and the rest of it.
Arinola Dorcas. Yeah, I agree with that. So, I don't know if there's anything you like to say.
All right. So I think having this conversation has opened my eyes to a lot of things. I mean, hearing from Anita from Tanzania, hearing from Sarah from Ghana, and then having to share my own perspective as well from Nigeria. It has opened my eyes to a lot of things, and it has really showed me what's the gaps that we are having in the maternal health care systems, and how each person is trying to do as much as they can to make sure they create awareness, to make sure they're on the advocacy journey, to make sure they wear the advocacy cap to ensure that every mother stays alive and every child stays alive, right? I'm super excited that we did this for us to get different perspective from different people, and we exactly got that perspective from each and every one of them. So I'm super excited that we're able to do this. Thank you so much to our speakers. Thank you, Anita from Tanzania. Thank you, Sarah from Ghana. Thank you to our able moderator, Vivian, on how you coordinated and you moved the flow to ensure that we get the questions and we provide answers to it. And I mean, thank you to my own self. I would appreciate myself as well. But more, thank you, Vivian. But I'm more happy that we're able to get different perspective and we are able to look into corners and see that yes, we are doing this work. What way forward can we do? What other thing can we do? How do we get more people to move in the policy? How do we get more people to give solutions? And most importantly, how do we get to learn from each other? Look at when Sarah was talking about setting up a free primary health care. What if, who knows, maybe sometimes later I can start also pushing for how we can get a free healthcare in Nigeria. I don't know how that will be possible, but if it can be doable in Ghana, it can be doable in Nigeria. Look at when
Yeah.
her name, yeah, Anita was talking about in Tanzania how she was able to do the breastfeeding clinic and the rest of it. I mean, if she can do it there, why can't we do it in Nigeria as well? And when I was also sharing about the policies, the favorable policies, and about our community, when I was also sharing how maternal health can be implemented and not just creating awareness. How can we involve women? How can we get women to be part of it to ensure that everything that we are saying is being implemented? So to me, it's like we have achieved our goal. And I truly appreciate each and every one of you. For those that joined, thank you so much for joining. For those that have not joined, maybe due to one thing or the other, we are going to share this link across all our social media so that everybody can always join and everybody can always listen to this. That was what the reason why we streamed it on YouTube so that each and every person can be able to get them later. So thank you so much, everyone. Thank you. I think that's all from my end.
So I
So I
think
think that's it from my end.
so. Vivian, are you there?